families, and caregivers. On behalf of the Crozer Keystone Health System, I'm honored to welcome you to our Crozer-Chester Medical Center for this special presentation of our medical grand rounds. This is the second PMP Symposium at our institution. My name is Patton, and I'm a surgeon and deeply committed to the cancer program here and serve as the Cancer Center's physician liaison to the American College of Surgeons. We are proud to team with the PMP Research Foundation once again to provide the opportunity to learn about a condition that is perceived by most as a mysterious diagnosis. Pseudomyxoma peritonei is a condition that is often misdiagnosed and mistreated. After last year's symposium, I thought it was critical that we bring this information to the attention of all physicians who may be caring for patients undergoing abdominal surgery. We physicians need to be on the lookout for PMP so that patients can get an accurate diagnosis and treatment and begin an appropriate process that their lives depend upon. We are fortunate today to hear from the expert physicians and patients who are the most experienced and knowledgeable in diagnosing, treating, and living with PMP. I'd like to acknowledge the outstanding work of Drs. Sugarbaker, Lambert, Esquivel, and Sardi, and the board of the PMP Foundation, and thank them for helping to remove the mysterious shroud covering this diagnosis. We appreciate that you have taken the time from your busy schedules to come here and share your expertise with us. I would also like to thank Tony Borda, Vice President, Clinical Services and Clinical Support of Crozer-Chester, and Patty Hollenbach, Nurse Navigator, who have been instrumental in developing this program today. The main goal of our program this morning is to raise awareness about PMP so that physicians and surgeons will be more readily able to recognize and know how to go about treating it. We want to be able to advise and counsel our patients we encounter with PMP with confidence and compassion. I am sure that after today's session, we will be able to do that. I'm anxious to get started with the program and am pleased to welcome Mr. James Carroll from the PMP Research Foundation. He will begin the official program and introduction of the overview.
Thank you, Dr. Patton. The PMP Research Foundation is proud to collaborate with Crozer-Chester Medical Center through sponsorship of today's symposium. Let me begin by thanking Dr. Patton, Tony Borda, Patty Hollenbach, Marie Harrington, and the entire planning committee for an outstanding job creating today's symposium. I also want to welcome today's presenters and patients who traveled from as far away as Canada to be here today. I'm very excited to take a few minutes and share our foundation's story with you. For most of our board members and many of our supporters within the patient community, our stories are very similar. The story begins with the diagnosis of PMP, appendiceal cancer, or oftentimes a misdiagnosis of PMP, followed by a struggle to understand this disease and seek out potential treatment options. Often this occurs in an environment where the doctors being consulted for treatment and diagnosis have never been exposed to PMP and have limited or no knowledge of the disease. For patients, it can be a roller coaster of emotions, with decisions being made having life or death consequences. For Judy Culbertson and I, that journey began in 2004 when our beloved husband, Dutch, and my best friend, was diagnosed with PMP. Dutch lost his courageous battle to PMP in 2006. Following Dutch's passing, Judy set out to make a difference for Dutch by raising funds for PMP research and education through a cancer walk just a few miles from here in Ridley State Park on Father's Day. Only after starting the walk to discover that there was really no central charity to donate to. In late 2008, as we considered creating a foundation, we were fortunate to discover the newly formed PMP Research Foundation. The foundation was created by Lisa Luciano, a courageous PMP patient from Ohio, the mother of 8 children, who recognized the need to support the medical specialists through funding research. Lisa created the foundation along with her co-founders, a group of individuals affected by PMP, many of whom are here today, including Jerry Lewandowski, Mike Dvorsky, Dan Luciano, and Kathy Hoover. Susan Ortega, Judy, and I subsequently joined PMP RF shortly after they founded the foundation was initiated. The PMP Research Foundation is an all-volunteer organization, and our mission is personal and it's from the heart. Board members volunteer their time after their full-time careers for this cause, sometimes between treatments and hospital stays. Although we are in our infancy stages as a foundation, we have begun to build an organization that will hopefully improve the quality of life for patients and hopefully someday bring a cure to PMP. Simply stated, our mission was to fund research to find a cure for PMP, with our primary goal to raise $1 million during a 3 to 5 year period to fund important research. Our primary method for generating funds is through general donations and cancer walks. The Dutch Walk, which is our walk, which is held at Ridley State Park every Father's Day, has its 5th year anniversary, and we have tremendous local support of PMP patient families, and we have consistent support from people like Don, George, and Thea, who are here today, who come down from Canada every year. The Summer Scurry in Ohio, where Lisa and Dan Luciano and their family run that. We just held our 3rd walk, Pump Out with Jeff, in North Carolina in May, current PMP patient. And Brenda Carawan is actually running in an ultramarathon in July, 135 miles for her friend that has PMP to try to raise money. She told me to mention if anybody wants to join her today, just tell us at the end of the program. But year to date, our total fundraising has now, with the Dutch Walk this year, we've surpassed $500,000. We're positioned through our infrastructure and fundraising website to grow and accelerate fundraising and research. Given the fact that we've received additional involvement by volunteers in the PMP community, continued support by the specialists, and in October of this year, we are projected to surpass $600,000 and will be well on our way to our target $1 million within 5 years. What do we do with the money? Our research grant program is administered by the National Organization for Rare Disorders, including RFP development and scoring responses in order to select the awards. Time does not permit me to go into the details of each individual award today, but I just wanted to show you kind of the range of doctors that are receiving the grants. In 2008, we were able to issue 3 grants, some very prestigious individuals, and in 2009, and in 2010, we were also able to issue 3 grants, and this year we are targeted to do the same. So, year to date, total of 6 research grants for $300,000. We have 2 or 3 grants that are already funded for this year and in the pipeline with NORD. The formation of our Professional Advisory Board of Specialists last year and the creation of our PMP education series of symposiums will also serve to strengthen our foundation. To our specialists here today, Dr. Sugarbaker, Dr. Escobar, Dr. Sardi, and Dr. Lambert, we thank you for your leadership, for being pioneers, and we thank you for your support and ask for your ongoing support and participation and guidance of our foundation. We pledge our support to you in return. To the doctors, nurses, and students in today's audience, we are appreciative of your attendance and firmly believe that you'll be able to apply the education you receive today and affect the outcome of patients in the future in a positive way. To the patients in the audience, we want you to know that you're not alone, that we are here to support you and invite you and your family members to join us and support us. Stay strong and never give up. During today's session, you will gain great insight into this disease from the specialists and hear some very compelling patient stories. Lastly, I want to thank Judy Culver. After Dutch's death, she could have moved on like many people do, or been the recipient of charitable events for her own family. Instead, she very courageously chose to continue to honor Dutch's memory through her persistence in fighting this disease. Thank you very much.
Thank you, Jim. I'm Jerry Lewandowski. I'm also the director of the board for the PMP Research Foundation. And I would just reiterate everything that Jim said, but I'm also here to introduce our keynote speaker. Dr. Paul Sugarbaker is from the Washington Hospital Center in Washington, D.C. He's the director of the Peritoneal Surface Malignancy Program at that institution. In addition to performing surgeries, Dr. Sugarbaker has acted as a mentor and an investigator. He's lectured nationally and internationally, and he specializes in gastrointestinal oncology and colorectal cancer surgery, especially with rare diseases such as pseudomyxoma peritonei, peritoneal mesothelioma, abdominal sarcomas, and peritoneal carcinomatosis. And it's hard to believe that I can say all of those words. But Dr. Sugarbaker is clearly a pioneer in the area of cytoreductive surgery with heated intraperitoneal chemotherapy, and has published over 850 scientific articles. So he's truly a distinguished speaker, and we're really proud and grateful for him coming to share his time with us today. Dr. Sugarbaker.
It is a distinct pleasure to be here this morning. A lot of familiar faces in the audience, and it's going to be, I think, a very interesting morning for all of us. I'd like to turn things around a little bit in my initial comments and say that PMP research is definitely important, and we are an orphan disease, often without anyone providing a solid infrastructure for treatment. But PMP has been a catalyst for a whole new dimension, sometimes referred to as the last frontier in oncology. And PMP as a disease and the success that has been gained through PMP has now infiltrated, metastasized. It has infiltrated into the rest of oncology. Laura Lambert is here. Laura Lambert is given credit for infiltrating the ivory towers in Massachusetts with chemosurgery. And we have this whole new concept that the two most powerful tools for dealing with this dread disease we call cancer are surgery and cancer chemotherapy, and we don't want to short circuit radiation therapy, but as far as curative approaches, those are the two most prominent treatment modalities, and now we're bringing those two most powerful treatments together into one place. We're bringing them together in the operating room. And we can do interesting things. with the chemotherapy that cannot be done at any other time in the patient's cancer career. We can heat the chemotherapy, we make it more cytotoxic. We can heat it so that it now penetrates more efficiently into small tumor nodules. We can achieve practically perfect distribution of the cancer chemotherapy to the residual cancer cells. You know, when you just put the drug into the vein, it gets to one part of the cancer but not another, depending on the blood supply. We're getting the chemotherapy there consistently in all of the patients who have what we call a complete cytoreduction. And of course, we have large surgical requirements, and then we have large requirements for the knowledgeable use of this chemotherapy in the operating room. And, coming full circle now, we need efforts by groups such as the PMP Research Foundation to move these concepts and these realities in patient care, to move them along. There is quite a lot of resistance for reasons I don't quite understand in the U.S. We don't have such resistance in Europe, it seems, and there's somewhat of a different. I think the U.S. should be ashamed of itself in terms of the progress that has been made in comparing ourselves to Europe, to Holland, and now efforts in Germany that are so outstanding. But anyway, that is the reality. I would like to just make a few comments, if I could, about where this disease has begun to take us. We just finished a PhD by Kurt van der Spieten. Many of you were at the Uppsala meeting, the biannual meeting, and so we just finished a PhD thesis. And one of the things that we're trying to do at the hospital center with our research efforts is to come up with a perfect HIPEC. I think most of you know what HIPEC is. I'm sure I like that name, but I'm stuck with it. HIPEC is the hyperthermic intraperitoneal chemotherapy, and there are probably 20 different HIPECs around the world. I don't know which one's the best. If we can come up with some research plan whereby we would decide on which one is the best, I'd be most happy. But anyway, we did these pharmacologic studies to try and by in vitro tests and by analysis of tumor nodules from patients and plasma and peritoneal fluid samples to come up with new plans. Not only for PMP, but for other diseases that have this peritoneal surface component. And you know, PMP is not alone, is it? The nurses from the Oncology Infusion Center here at Crozer are telling me that you're very much into the intraperitoneal chemotherapy for ovarian malignancy. And you know what? PMP did a large part of the groundbreaking for the current management of ovarian cancer. And some of those, the earliest protocols, Dr. Esquivel wrote a couple of research papers on it when he was with us. Some of the earliest protocols exploring this long-term use of intraperitoneal chemotherapy for a PMP, I think, were part and parcel of Dave Albert's efforts to do the randomized study to show the superiority of intraperitoneal cisplatin to systemic cisplatin for ovarian malignancy. Now, another thing that we're doing, and you know, Jerry, you've been able to accumulate here some of the real world's experts and definitely the national leaders so I had to use this opportunity to kind of explore some collaborative efforts. So we've got a research plan here entitled Integration of Cytoreductive Surgery and Hyperthermic Intraperitoneal Chemotherapy into the Management of Primary Colorectal Cancers at High Risk for Local Regional Recurrence. Now that's a mouthful, but what we're saying is that colorectal malignancy, one of the most common malignancies, we think should be attacked from the peritoneal space with chemosurgery. And I hope that we'll be able to put together a phase 2 multi-institutional study. You know, multi-institutional studies in the U.S. are really tough. And I was talking with Dr. Patton about how hard it is for us to get together as a group in the United States. We have so many medical, legal, and confidentiality considerations. And I'll tell you, in Europe, it just happens automatically. You don't even ever plan to do a single institution study. It basically is throughout the 25 treatment centers in France. That's just the way it happens. I don't know that I'll be able to have any impact on that. Now, the other thing, one of the most dread diseases in cancer, the one that hits people in the prime of their career and in the prime of their life, and then takes them within 6 months to a year, is pancreas malignancy. And so we've now put together a protocol to use hyperthermic intraperitoneal Gemzar. There's really only one drug that seems to be of value for this disease, but maybe that's actually not totally true now, and we'd like to integrate other drugs as soon as we can perhaps get 12 patients treated and show that what we're doing is safe. But again, thanks to PMP and the success that we've had with chemosurgery in PMP, we're now trying to apply this intraoperative hyperthermic chemotherapy to pancreas malignancy, and then, in the long run, treat these patients not with Gemzar going into a vein and hoping that some of those molecules get to the site where the cancer is, but actually using an intraperitoneal port, something I'm sure you're accessing over there in the infusion center on a daily basis, putting the drug into an intraperitoneal port and getting the chemotherapy right where we want it in these patients. So anyway, that's a little bit of what research is going on at our institution, and we are making continued progress. And I was very excited to see the list of names that Jim Crozer presented in terms of where the money has gone from the PMP Research Foundation. I recognize a lot of those names as really the prominent leaders in PMP programs in Great Britain and here in the United States. I've got just a few minutes to tell you about where I think chemosurgery, I don't know whether I like that name or not. This is a new designation for cytoreductive surgery and hyperthermic intraperitoneal chemotherapy for carcinomatosis. Okay, chemosurgery is what we're talking about. It's chemotherapy and surgery put together in one place. The two most powerful tools. I'm an old ROTC man, Reserve Officers Training Corps, and we used to take all these courses when I went through college about strategies for winning a war. And I tell you, the number one strategy for winning a war is concentration of force. Okay, I mean, you've got to meet the enemy and succeed at least at one point. And I think that what we're doing with PMP is the model for bringing concentration of our cancer-fighting forces together. All right, let me make a few comments here about a standard of care for peritoneal dissemination. Now, there is going to be some redundancy with the other presentations, but I think that that's acceptable in this type of program, and I think it'll tend to focus us on those things that are really important. Now, I would be remiss if I didn't say to, and Jerry, I hope you'll be present. I know you were in Uppsala with us, that we have important regional and national meetings in peritoneal surface oncology, and they must continue. I think most of us are on our way to Germany at the beginning of July for the important meeting in Regensburg, Germany. But we would like every other year to get everyone together. And the place that we've chosen, our executive committee for the peritoneal surface oncology group has chosen for the next meeting is Berlin. Interesting, we never had the meeting in USA. It's a tragedy in some respects, but 90% of the participants every year are from Europe. So moving the biannual international meeting to the U.S. has not really made sense to us yet, but hopefully before I pass on the baton, we'll have a meeting at the hospital center in Washington. But I'd like to invite all of you, physicians and patients, to come to Berlin October 31st to November 2nd of 2012, www.peritoneal conference 2012, and it will be an experience. I guarantee you there is always a patient participation in the meeting, but it will be a sharing of the most up-to-date and avant-garde approach to this really terrible part of the cancer process. I just saw at ASCO abstract, and what they tried to do is ask the question, if you're going to die of colorectal malignancy, what component of the metastatic process takes your life most quickly? Well, I have to say, with my experience, is if you get brain metastases, that's going to take your life quickly. But if you're looking at liver and lung and retroperitoneal nodal or peritoneal metastases, what's going to take your life more quickly? Well, you're going to die twice as fast with peritoneal metastases as you would with any other metastases. Your life is going to be cut in half just by the fact that you have peritoneal metastases. And this is data from several thousand patients. So this component of cancer is one that deserves our particular focus. And yes, I'm hopeful that we can, with some collaborative research efforts, prevent this focus or this component of gastrointestinal cancer. So anyway, there's going to be a lot of interesting things that happen at Berlin. This effort in peritoneal surface oncology has built over the years. We did have near to 500 participants when we started back in 1998. It was myself and my research fellows and Brendan Moran